Thank you. It's an honor to be invited and to be here on this very interesting session. I have no disclosures to make, but if somebody wants to make an offer I can't refuse, please respond. For understanding the tissue acquisition, I focused on the difference between biopsies and resections. So the context of perception, I'll start with that immediately. You see here an image, and you can see whether you see an old or a young woman. That's an option. It's just for yourself and your perception. If you see now the old woman, you can see the eye and the lips. And if you see now the young woman, she looks away and she has a color. So what it actually means is that you get one image, but you get different interpretations. And that's important. I showed already to the audience here the box. And I like to show it also for the people who are online. If this is an alveolus, and during surgery the air goes out, you will get a smaller volume of the alveolus, but you need to have an adaptation of the alveolar wall to some extent. But this alveolus in the lung is much more complex than a simple box, including all the pathology already present. And you can calculate what the difference is between the volume and the surface required for that specific volume, and it ends up in this graph. Here you can see the volume of the box when you make the ribs smaller and the box flatter. And this is the required surface for that box, meaning there is an excess of surface with the smaller box. That excess of surface you can also imagine in the model here on the left side. I said to my wife, this is a bunch of grapes, leave it in the kitchen, this is science. She got bored and I had to place it somewhere on the top of the closet. But I left it, and after 2 months, the weight was reduced to 25%. The difference is between the full grape, the full volume, and the reduced volume. But the skin of the grapes did not change. So there's an automatic adaptation of the larger skin to the smaller volume. When you now make sections of it, you will see infolding of the skin of the grapes. In fact, if you look at the lung and what pathologists expect in vivo, they expect air. And when you see a monolayer of tumor cells with air, all pathologists will be aligned and call this adenocarcinoma in situ. But when the air goes out, you get a different pattern. You can get a pattern where there's only slit-like spaces, which looks like papillary carcinoma. If you have slightly more air, it looks like acini, so they call it invasive acinar adenocarcinoma. It can also be a kind of cutting that they will call it solid or micropapillary. But if you realize these effects and adaptate your interpretation of the same lesion in the modified classification, all these 3 examples are clearly adenocarcinoma in situ. So go back to the actual morphology and don't think in terms of patterns. Patterns is wallpaper matching. This is papillary, so we call it papillary invasion. Think twice. This is published, and the modified classification takes into account the effect of the collapse. It has a much better reproducibility by 40+ pathologists than the WHO classification, and it has less variation in PT staging. It's in line with biomarker analysis, including follow-up. So for a resection specimen, if you think about it as a non-solid lesion, in vivo you will recall that it will have a lot of air. If you calculate it in a model of an alveolus with 200 micron diameter, it's still more than 50% air. But during surgery, the air goes out, and then you can make an estimate. And we did the estimate for the cases from New York, from David and Claudia, and you get a reduction of air to 10 or 20%, depend on the way you handle it. So you can solve it by perfusion fixation, and then you create clear spaces, and the clear spaces are interpreted as air. This is an image I got from Yeung Sang from Seoul, and here on the left side you see the syringe into the bronchiole, and it fills nicely up, but there's still an area which is not filled up, and that can be solved by adding a syringe and then specifically infusing that area too. And what do you get? This is the most beautiful picture I saw from Korea. You see here the edges of a secondary lobule with the vein, there and there. Here you see a pulmonary artery, a respiratory bronchiole, alveolar ducts 1 and 2, and including all alveoli, these are all aligned by one monolayer of tumor cells, which is just the definition of AIS. So with refilling, you get an impression that everybody will agree on this type of diagnosis. However, one of their cases showed this. So there was partly refilling of the space, but partly it wasn't. If you now look into detail, you can see if there's a lot of air, it's a monolayer of tumor cells. But on the other side, it's folded up. You see kind of papillae. Still, it's only a monolayer of tumor cells. So also in the very dense impressed area, it's nothing else but AIS. I got another example, fits for me perfectly with one of the cases shown this morning. I bet that if this room was filled with pathologists, and without knowing this, more than 90% would call this papillary carcinoma. But actually, the air is out in the middle, you got slit-like spaces, and if you look on those stroma elements, it's only a monolayer of tumor cells. So, one image, two different interpretations. You have to be aware of the effect of the collapse. The second thing is, this case has slightly thicker walls in the alveoli. That's frequently a reactive phenomenon with elastin. It's not a sign of invasion, but it may mean in vivo that you get less air than the 50% with AIS without thickening of the walls, and that you get not enough air to make it white. But the radiologist will think white invasive. Frequently heard. But it may still be in situ because of the additional stroma components. So not every non-solid lesion is by definition invasive. Perfusion fixation is standard in some countries, Japan, Switzerland, and it's performed in individual laboratories in Korea, Italy, the Netherlands, and Amsterdam. Suresh, it's done already a while, and in the UK. And the last thing which is important for tissue acquisition is a quick transport to the pathology laboratory. Fixation delay gives nasty appearances. A recent review only is before actual printing, it's available on the website, is artifacts in the literature. Fixation delay effects are present in resection specimens in the Korean series in 40% of the cases. Interesting for you also. And this is just an example of tumor cells in the blue ovals, which are detached from the wall and lying in the lumen. And here you can see adenocarcinoma in situ, but by the delay in fixation, the epithelial cells get detached from the walls, from their positions, so they look like micropapillary or accumulate in the lumen, and then you get an impression like it might be solid or micropapillary, and even spreading around by some manipulation. Tumor cells have the consistency of a raw egg, but then without a hard shell. So as a surgeon, it's difficult to feel, especially in situ. You heard this morning about finding the in situ lesion with additional techniques. And here you see again that the epithelial tumor cells are detached from the wall by delay in fixation. And again here, somewhere away from the initial tumor, you see things which appear easily stas or micropapillary, whatever you want to call it. But it's just an artifact by delay of fixation. So in my opinion, I should not use these areas to make a diagnosis. So the take-home messages are quick and cold transport to pathology, prevent fixation delay, perfuse through the bronchus to restore the alveolar air and better recognize the pattern and actually the morphology, the underlying morphology, and avoid overdiagnosis of invasive adenocarcinoma. And I predict that a better recognition of AIS may lead to more diagnosis of AIS, especially in all non-solid lesions, or practically all solid lesions, non-solid lesions, but also in part solid lesions on HRCT. And for those who I made this photo yesterday during a small walk after arriving on the plane, which illusion do you believe? Is the ship sailing or invading into the air or attached to the wall? You can have different interpretations, that's up to you. But that's the same for pathology in the lung when it's collapsed. Thank you for your attention.